the steps for collecting PKU. And remember, PKU is collected within 24 to 48 hours or 72, right? Here we go. We said the first thing that we're gonna do is a heel warmer. A heel warmer is to stay on for at least 3 to 5 minutes, okay? What else do I need to know? What else do I need to know when it comes to PKU? First of all, how are you collecting a PKU? What type of equipment am I using? What do I need? Okay, so we're gonna use a lancet instead of a actual 23 gauge needle, right? When we need a 23 gauge needle, when is that? Is that for my newborns? When I'm going to use a 23 gauge needle, who is that for? 2-year-olds. So now I know that I need my lancet. What else do I need? I have my heel warmer ready. I'm leaving it on my little baby for 3 to 5 minutes, and then I'm going to puncture. Where am I going to puncture? Am I gonna get it in the little finger? Is it in the wrist? Where am I puncturing when I'm going to collect for a PKU? The heel stick, okay. Okay, so it's a heel stick. And what is the depth of my heel stick when it comes to my pediatric baby, my newborn baby? 2.0 mm. That is my depth. Okay, so now I know my PKU needs to be collected between 24 to 48 hours. After that, I applied my heel warmer. That needs to be on 3 to 5 minutes. And then I'm going to use a lancet. I'm going to puncture them in their heel. Now, when they talk about I'm doing this because remember the heel is right here and we have to do it like this. What is that positioning called? Here's my heel. I have to do it on like that, right? I have to make a little X. Lateral, yes, remember that term. We are going to puncture it lateral. Now, if we're puncturing it laterally, and we know that we could only go 2.0 mm, what is the baby at risk for if I go 3.0? Yes, osteomyelitis. Osteomyelitis, yes. Okay, so we're going to puncture it laterally, and if we go too far in, it will cause osteomyelitis. Now, what am I using to collect for a PKU? What am I using to collect, y'all? What is it? What is that card called? It's a filtered card. Yeah, so it's my filter paper. Now with the filter paper, remember there's specific instructions for this. Don't give up on phlebotomy. No way. Don't do that. Don't do that. Have you checked for any blood centers, plasma centers, and dialysis before you give up? So filtered paper. Now, what is important about this filtered paper? There's a certain way that we need to collect it on a filtered paper. What do I need to know? Okay, do not oversaturate. So that means I have to fill each circle. I have to saturate each circle, right? If it comes out to be a different color other than like a reddish brownish color, what does that let me know? It means that we have some type of contamination. If we know it's supposed to be like a reddish or a brownish color and it comes out to be blue, we know that there's some type of contamination going on, and then we have to repeat. Now let's say that you punctured and it's not enough blood. You see, like we're squeezing, we're doing a little squeeze, and it's not enough blood. What do you think your next step should be? What can you do? What can I reapply? I just gave you the answer. We're gonna reapply the warmer. We're gonna let it get warm just a little bit again, just so that the flow can come through. Again, you can, but we always suggest to just reapply the warmer just to give it that little touch, because we don't want to keep poking them. Remember, they're just born, so their blood maximum volume is very different from a their blood volume is very different from a 7-month-old or a 1-month-old. Okay, so there's only so much that we can take from them without them falling into like a, oh no, you don't have enough blood. Okay, so we don't like to keep sticking our little babies. So that was part of our special collection. Do you guys have any questions? My gosh, we spent like a whole hour talking about special collections. Do you guys have any questions when it comes to that? Oh. Is there any questions? Are we good? We understand special handling. I'll say it one more time. We'll go over real quick, okay? So the first one, we have our ammonia and arterial blood gas. If everybody could unmute and respond. Here we go. You didn't get the Zoom link? Do you want me to send it? Okay. Alrighty, here we go. When we talk about ammonia and arterial blood gas, what is important about that? What do we need to know? And what additive is needed? Heparin. We talk about lactic acid. Lactic acid is considered to be a special handling because of what? Is collected in We need sodium fluoride. It is a gray tube and it's chilled on ice. All right, our next one. Bilirubin is important because of what? Light sensitivity. That means I will collect it in which type of vial? Amber, or how will I protect it from light? Okay, I will wrap it in foil. Our next one, we have time sensitivity. Remember, we have a non-blood specimen, and then we also have a blood specimen. So let's do the non-blood specimen that is considered to be a time sensitivity. What is it? I'll give you guys time to answer. It's a non-blood specimen. It's our semen. Wonderful. Now we're going to go to our blood specimen. That's also a time sensitivity. Remember, I can only collect this within 8 a.m. or 9 a.m. Which test is that? It's my cortisol. Absolutely. Now we're going to go over to our non-blood specimen again. We're into the stool category. We have our C. diff and our H. pylori. How will I send that to the lab? How would I send that to the lab? Frozen. And if I'm sending it to the lab frozen, that means it's collected in what type of container? Not, yeah, sterile too. Is a non-preservative. Now we're gonna go into our alcohol level. What do I need to know? What's the main important thing when collecting no alcohol? And what's a different antiseptic that I need to use when I'm dealing with the alcohol level? Iodine. Wonderful. Now we're going again, we're talking about our non-blood specimen, and this is our urine. We're in the urine. We have 24-hour urine, we have clean catch, we have midstream, and we have a routine. When we talk about any type of urine specimen, the most important thing is my timing. Okay, I can also, with my 24-hour urine specimen, I can collect creatinine and my hormone levels. What do I need to tell my patient as a form of instruction when they are collecting a 24-hour urine specimen? Keep it refrigerated. If a patient were to ask you, you're collecting a urine specimen from me, why? What are you looking for? My kidney functions. Exactly. Alrighty, so that was a quick sum up of our of our special handling. Now we're gonna go into routine collections. This is another category. Remember, our main categories that we will be tested on, it doesn't matter what exam you're taking, whether it's the AMT, the NHA, the NCCT, the ASPC, they will always give you these main categories. These are the main categories of phlebotomy. All right, so it's safety and compliance, patient preparation, routine collection, special collections, and processing. And we just went over special collections. Now we're gonna go to routine collections. Routine collection, what do I need to know? What do I need to know with routine collections? This is where our beautiful vials come in, different tests. What can happen to our samples? When we talk about hemolysis, what did we say that hemolysis is? What is the definition of hemolysis? Destruction of red blood cells. Wonderful. What can cause hemolysis? Let's write this in there. Hemolysis. Hemolysis. What can cause hemolysis? Vigorous. Yep, we're gonna do vigorous shaking of the specimen. What else can cause hemolysis? Talk to me about my needles. Talk to me about my tube size. Talk to me about what else? My timing. What can cause hemolysis? What can cause my specimen to look reddish, orangish? Not hemolysis. The tourniquet is left over. Absolutely. So clotting time, let's put not waiting for proper clotting time. And what is the clotting time for my serum separating tubes? Because remember, that's the only tubes that we have to worry about when it comes to clotting. What is my proper clotting time? It's it's at least 15 to 30 minutes. All right, so we have the vigorous shaking. That's going to cause hemolysis. My sample is going to come out like a reddish color. If I'm not waiting for my blood to clot properly, it's going to cause my specimen to be hemolyzed. What else? We said the wrong size needle. Talk to me about that. Talk to me about that. The wrong size needle. What does that mean? Let's explain it. Tell me what's a normal vein. Talk to me about that. Let's really understand why in the world, if I use a 23 and I'm trying to collect in this big vial here, would my blood become hemolyzed? Why, if I didn't insert my needle correctly and it's pushing up against the vein, why would my specimen become hemolyzed? Let's talk about it. Tell me. Explain it to me. Cephalic vein? You got it. You got it. So if I have a regular size, beautiful, healthy vein, okay, this is a normal size, and I decide to use what size needle would make me, what size needle would give me an example of a small size needle that will cause hemolysis, and I'm trying to collect it from a beautiful vein? So my 23 is my 25 gauge. Remember, the higher the number, she was shocked. She said, "Hold on." That girl was shocked. I know that's right. All right, so the higher the number, the smaller the needle gauge is, okay? The higher the number, the smaller that it is. So we're getting to 23, 25, 30, right? These are small, tiny needles. They're baby needles. But the lower I go, I'm at 16, 17, 18. These are huge size needles, okay? So now, if I'm puncturing, my vein looks good. I put a tourniquet on, wonderful, and I'm trying to use a 23 gauge needle, my blood will be hemolyzed. Again, using a 23 gauge needle is a slow flow. It's a slow flow. Usually it's used for our hands, which is also considered to be the dorsal puncture. And we'll use it on small, fragile veins, okay? So that's another one I want y'all to put. Let me put this here in the chat. Needle size. Remember, needle is small, but the vein is a healthy vein. So needle size, too small, and the vein is big. There we go. So hemolysis, vigorous shaking. What is the normal way of shaking? Do we even shake? How are we supposed to? We don't shake, period. So we invert, and what is the proper definition for inverting? What is the proper definition for inverting? To gently mix, right? We're going to gently mix what? And the blood. Okay, so I'm gonna put that in here. Invert is to gently mix additive with blood. Okay? Invert means to gently mix the additive with the blood. Yes, in a figure 8. Yep. The infinity sign, just like that. We're just going to go like that. We're not doing this. We don't want to call back our patient and be like, "Hey man, I don't know what the lab did," even though we know we did it, right? So we're not, we don't ever take the blame. What? I messed up. You lying, but come on in, come back in, it's cool. Free of charge, right? That's what we'll tell them. But inverting is gently mix the additive with the blood. So we know that the needle size has to do with hemolysis. Tell me, if my needle, let's say I'm doing a regular venipuncture and my needle is vibrating, what does that mean? No. My needle starts to vibrate and I'm looking at my tube and it's like a splat, splat, splat of blood coming out. What can you conclude? What can you conclude? Tell me. It's just, did I go through the vein? How would I know if I went through the vein? Not pressure. Oop, my coffee almost fell. Not pressure. I'm not looking at it going like this. It's just little splats of blood. Blip, blip, blip. The tube lost volume. Give me another one. I'm not in the vein. I'm not in the vein. So what am I? Yes, I'm on the side of the vein. I am hitting the wall of the vein. Here's my vein. Here's my needle, right? I'm on the side of the vein instead of being right inside of my vein. I'm right here. At this point in time, I feel my needle going zzz, zzz. What is the proper thing to do? What are we going to do? Are you just going to push it in some more? You're going to pull back, and then you're just going to push it back in. That's it. We're not fishing. We're not going to the side. We feel the vein is all the way over here, and we're like, you know what? Let's just angle it this way. We're not doing that. So if you ever feel that your needle is vibrating, you'll feel it. It's rubbing up against the vein of the wall. You need to pull back and then go in. That is it. You will either always go in a little bit more or pull back. That's the only thing. When I say anchor, this term that I use, anchor, what does that mean? What does anchoring mean? When I say anchor down, if we're learning how to stick together, right, and I'm going to say anchor down, what is the first thing you're going to do? Are you just going to look at me and be like, Chad, what you trying to say to me, man? What you going to say to me? What does anchor down mean? To hold the skin. So this is what anchoring is, you guys. Okay, this is anchoring. So this is just pulling down on the skin. When you anchor, okay, when you're anchoring down, you're creating that non-movement of the vein. This is used for any type of veins, okay? Whenever you say, oh my gosh, you have a rolling vein, anchor down. You're pulling down on that vein. You're holding it so that it does not move. So anchoring, holding down on the vein. Anchoring is okay. So we learned two new words. Well, there's vocabulary words here. We have our inverting, which we will gently mix the additive with the blood. And how do I know that my tube has an additive inside of it? What gives it away? Remember, additives equal what? Here we go. Additives equal anticoagulants, which also equals inverting. Anticoagulants, and it equals inverting. Okay. So now, we talked about hemolysis and what can cause hemolysis and how to prevent hemolysis. All of these terms that we talk about, whenever they're talking to you about routine collection, this is where your pre-analytical errors appear. This is like, what did I do for my specimen to do what it do, for the lab to reject it, okay? What is 1 tube? What is 1 tube? The lab will definitely say, you playing. Go back. My light blue tube. Let's put that in there. My light blue tube. Light blue. My light blue tube. What's important about my light blue tube? What category does my light blue tube fall into? Yes, light blue tube, coagulation study. Okay, my light blue tube, it falls into coagulation study. What is my additive? Sodium citrate. We will invert it how many times? This is the only one that have a specific time. How many times will I? 3 to 4 times. All right, give me an important test that goes along with my coagulation study, sodium citrate light blue tube. Not bilirubin. Not bilirubin. Yep, so we got our PT, PTT, and PTINR. PTINR, real quick, can also be collected how? Using what type of testing? If I don't want to do a venipuncture, I can also do a PTINR how? Capillary. Yes. Okay. Again, guys, if this cuts off on me, just relog back in. I hate it. PTINR. D-dimer. Thank you. Thank you for telling me that. So PTINR can be a capillary puncture, and if it's a capillary puncture, it is also considered to be, what is that 4-letter word? A CLIA waived what? Point of care. Yes, point of care testing. Here we go, just like that. PTINR can also be a capillary puncture, and it can fall under the CLIA waived point of care testing, which is my POCT. Okay, so that is what is important about this tube. Now, I don't know what the heck is going on. It will not let me go past 40 minutes, and I can't stand it. It's annoying to me. What else do you need to know when it comes to the light blue tube? So QNS. QNS stands for quantity not sufficient. What is the ratio in my light blue tube? 9-to-1 ratio. Okay. These are the informations that you need to know when it comes to our light blue tube. It falls into the category of coagulation studies. Remember, this is our little light blue tube here. We will invert this particular tube 3 to 4 times. What does inverting mean? We're just mixing the additive with the blood. Remember, any tube that contains an anticoagulant is originally collected in what form, you guys? It's collected in whole blood. Now, the only way that I will manipulate it or spin it down, and yes, you're right, it's 9-to-1. Anytime I will spin it down, where am I getting this information from? It's not just coming from me. Why would I spin it down? Facts. My requisition form will state we need sodium citrate in what type of form. If I'm spinning down my anticoagulant tubes, it will give me what? Not serum. Plasma. Let's put that in the chat. So serum comes from clotting activators, which will be my red, my gold, and my tiger. And then I have my plasma comes from plasma. I hate that. So if the doctor wants plasma from heparin, do we just use the tube with the gel? No. No, you will use your regular, that one or that one, without the gel. Okay, so if my doctor says I need plasma, but I need it to come from my heparin, it's going to be your regular. The only time that you will use this type of tube here is if it's a stat electrolyte. Okay, a stat electrolyte. That is whenever, just like you would use your gold top. Whenever we're doing any type of our tigers, our gold, we're checking for electrolytes. That's our potassium, our magnesium, our calcium, right? These are all different type of electrolytes. Then we're checking our lipid. You could do your lipid panel with this. You can do your TSH with this. What is a TSH? What is it? Thyroid stimulating hormone. So plasma comes from anti-thyroid stimulating hormone. Yep. Anticoagulant tubes. Plasma comes from anticoagulants. Thank you. Y'all just sitting up here getting all this good information. Nobody even liking or live. Man, come on. Alright, plasma comes from anticoagulant tubes. So we know that. Wonderful. And TSH stands for thyroid stimulating wait. But this one is like freezing up on me. Okay. Somebody. Wonderful. Okay. Here we go. So we said another vocabulary word that I would want you to know when it comes to TSH is hyper. Slash hypothyroidism. Okay. So TSH, a vocabulary word that I need you to know is hyper, high, hypo, low, thyroidism. We have some type of thyroid problem, whether it's elevated or it is not elevated. Okay. Now, something else that I need you guys to know when it comes to routine collection. So we talked about hemolysis and how to prevent hemolysis. I hate this. Not y'all, I'm sorry. I love y'all, but this thing is acting up and I don't like it. Yes, I can. Somebody just asked a question about infiltration. Somebody just asked a question about infiltration. Infiltration, I don't know what this is. Oh, well, hello. I'm sorry. I didn't mean to add, but hey, thank you for joining. All right, infiltration. When you are infiltrated, that means that there is that means that there's fluid outside of the cellular component, okay? That means that there is fluid outside of the cells, right? So infiltration is most likely whenever you are having an IV. Okay, and they didn't really put the catheter inside of the IV properly. You know, that little tiny bendy thing whenever they're inserting and then they remove the needle, but you still have a little wiggly thing inside. That is considered to be your catheter. Now, when the catheter is okay, I think somebody was recording. I don't know, but whenever the fluid is outside, so if you're getting any type of fluids running through the IV, it's going outside of the vein, and it's just infiltrating under the skin, right? So it's not really inside of the vein. Yes, it can. No, you're fine. I'm sending it again. I'm in now. Check the Zoom. I'm in now. Okay. Now, a hematoma cannot be caused if the tourniquet is too tight. A hematoma will not cause it if it is too if it's been on there too long. The only time you can associate a hematoma the only time you can associate a hematoma with a tourniquet, I love that question. Let me see what the heck? Here we go. The only time you can associate a hematoma with a tourniquet, we up again. One more time. The only time that you can, okay, yes, apply these permissions to all future requests. I'm gonna do that. So anybody that's trying to do it, try to do it now. Anybody that's trying to recording, try to do it now. Try to record. Neither do I. Hold on, let me see. Oh, it can only do audio. Hold on, let me see. I think if you click more. Oh no, it doesn't say no. Share? Is it share? No. Captions. It's next to app for me. I don't know. Let me see. What if I share? Maybe if I share? No. Nice. No. How did you do it? How did you record? Or is there like a... Is it in the chat? Nope, it's not in the chat. I would love to record this so I could post it on YouTube if anybody, so y'all can catch it, but I don't, how do I even do it though? That's crazy. Wait, let me see if I go here. Host tools maybe? Start video, no. I need to take a pic and show, oh yeah, okay, screenshot, no. Record to computer, right, but how do I do that? Am I sharing? I don't know. Screen from the device. Yeah, but will my sound appear? I need everything. If I record it, maybe I could, this looks different from yours. Oh, okay. Who can see the, okay, I don't know. Okay, so this is what I'll do. I'll screen record this with audio, and then I'm gonna try to post it on YouTube. Maybe it'll work that way. And if you guys want to go on YouTube and look it up, but I don't know how to. Okay, let me try to screen record. Let me see what I can do. I'm gonna screen record. My mic is on. Okay, good. I'm gonna screen record. Okay. I'm recording. So if you guys are following me on YouTube, catch this Zoom on YouTube. But I'm trying to screen record it. Okay, guys? So you guys can have this. I don't know. Alright, let's try this way. I'm sorry, guys. What on the Zoom window? Did you check to record media as well? I think so. Alright, let's continue. Alright, we were saying about the tourniquets, right? And the tourniquets, when it comes down to the tourniquets and hematoma, the only time, for the only time that a hematoma will occur with a tourniquet is whenever you are not doing the proper removal of your needle. Let me write that in the chat. Hematoma. First of all, what is a hematoma, y'all? Hematoma is a what? What is it? A collection of blood underneath. Let's just put under the skin. Under the skin, like a little blood clot, a little clot. Whenever they say oma, the suffix of oma is tumor, okay? Under the skin, that is what a hematoma is, a collection of blood underneath the skin, which with our eyes, which will cause what? What will a hematoma cause, y'all? We know that it's a collection of blood underneath the skin, but what will we see with our eyes? Okay, so the suffix of oma We'll put that here too so you guys can know. Suffix oma is tumor. Okay, so it will cause bruising or swelling, and that's what we will see. Now, when I say that a tourniquet will cause a hematoma, that means we know the proper way to remove or end our venipuncture is by removing the tourniquet. We remove the tube, we remove the needle, we apply our safety, and we put it into the sharps container. I'm gonna put that in the chat. So finishing or ending venipuncture, and that won't cause a hematoma. It's gonna hurt. It's gonna hurt because there's like bigger patients that have bigger arms, and it tends to roll, and they're gonna be like, "Ah, this hurts." So what I would recommend is if their shirt is long enough, you can tie the tourniquet on their shirt. Or to make it more comfortable, because I remember there was a patient that I had. She was like, "Man, I really hate how tight the tourniquet is." You can always apply a what? A blood pressure cuff, right? And we will pump it up to at least, when using a blood pressure cuff, you can pump it up to at least what? What number can we pump up a blood pressure cuff to? At least 40. It's at least 40, okay? You can pump up a blood pressure cuff to at least 40. I like to say 40 to 60. Depending on how small our patient arm is, we need to apply a little bit more. I like to go up to 60, like I said, depending how my patient arm looks. But in your textbooks, in your exam, it's going to tell you 40. Okay, so removing tourniquet is step 1. I know it's a lot. I know. I'm sorry. Okay, so we're removing our venipuncture, or ending the venipuncture. The first thing that we do is remove the tourniquet, then the tube, then our needle. Apply safety. Apply safety. We apply safety and then discard in sharps. Boom. So that is the only way that our actual that the tourniquet can cause a hematoma. Okay, a tourniquet itself doesn't cause like bruising, but it's the way that we do our ending of our venipuncture. So if we keep the tourniquet on and then we remove our tube, we remove our needle, and the tourniquet is still on, that pressure, not only is it going to keep the blood going, it's going to cause a hematoma, a bruising. Okay, so always remember, you're doing the tourniquet first. You have no? Okay. So we remove the tourniquet, the tube, the needle, apply our safety, and discard into our sharps container. Okay. There's so many things about the tourniquet. When we talk about the tourniquet, what is the purpose of a tourniquet, you guys? Pow, 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 pow. It's the flick, people. Wow. Where's the purpose of my tourniquet? Get out my face. Oh, I'm scared of a venipuncture. So, right. So we're going to enlarge. It's going to engorge. We're going to restrict the blood flow so that it can engorge or make the vein more visible to us. When I say palpate, which finger are you using to palpate? And what does palpating mean? Mm-hmm. Palpating is to do what? What is it? We are simply just going like this. We're just tapping. That's it. We're just trying to locate our vein here. Okay? That is it. To feel for the vein or the bounciness. Right. So we're just simply tapping. Why can't I use my thumb? Why? Exactly. The reason why I can't use my thumb is because it has a pulse inside of it. Now let's go and talk about what does a vein feel like? What does a vein feel like? What does a artery feel like? And what does a tendon feel like? I'll put it in the chat. So a vein feels like what, you guys? Bouncy. Okay, an artery. How do I know? It's followed by my pulse. And then a tendon is more of a what? It's hard. It's very rigid. Okay. It's hard. So we have a vein, it's bouncy. An artery is followed by a pulse. And tendon is usually very hard or rigid. Okay. Now, let's talk about hemoconcentration. We talked about hemolysis, what it can cause, how I can prevent it. I'm a great phlebotomist. You're in great hands. Your specimen is going to come back with the best results because I know how to handle my specimen not becoming hemolyzed. I'm going to use the proper gauge needle. If my vein is a healthy looking big juicy vein, what needle gauge will I use? 21. It's a 21 gauge. Okay, now let's say I have a little bit small, fragile vein. I see that I have a geriatric patient and a pediatric patient of age 2. What type of needle am I going to use? Right, a 23. Now let's say that we have blood donation. We need blood transfusion, plasma transfusion. What needle gauge am I going to use? 16, 17, 18, 16 to 18 gauge needles. These are the different types of needles. Now let's talk about the different type of veins. When I'm talking about, give me the orders of the veins that we should collect, of our main veins. Give me them in order. Cephalic, and basilic. Okay, so we have the median, the cephalic, and the basilic. Okay, tell me about the median. What is the purpose of that vein here? You got it. What is the purpose of the median vein? Yep. Anybody else? What is the purpose of the median vein? Come on, y'all. What's the purpose of my median vein? That's the first vein. Yes, that's the main vein that we're going to go for, you guys. That's my main vein. Okay, so cephalic is used for what? Obese. Yes, obese. Okay, obese patients. And then we have our last one, basilic. We try to stay away from the basilic vein. Why? Yes. Located next to artery. What's the name of that artery? Next to artery. What is the name of that artery? Our brachial. Wonderful. Not a nerve. Not so much a nerve. We focus on it being close to a brachial artery. Now, speaking of nerve, I love that. How will I know that? How will I know that I punctured a nerve? What is the signs and symptoms of me puncturing a nerve? How will I know? What will it be? Your patient's gonna say, ow, I feel a tingling sensation going up and down my arm, okay? That is what the signs and symptoms will be. It will be a tingling sensation that is going up and down that arm. That's how you know that you've punctured a nerve. How do you know if you've punctured? Give me 2 examples of how you know that you punctured an artery. I love it. I love it. It's going to be bright red. And what else is going to let me know that I've punctured a artery? It's going to be rich and it's going to go like this in our tubes. Boop, 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 boop. Okay? Remember, if I miss the vein and I'm only getting splats like bloop, bloop, it's either I'm not into the vein or whatever that may be. But if I hit an artery, it's going to be bright red. Why is arterial considered to be bright red? Ooh. It's oxygenated blood, yeah. So the reason why it's a bright red is because it's an oxygenated type of blood. And our veins carry what type of blood? Deoxygenated blood, right. Now, whenever does the artery or the heart, when the blood going towards the heart or away from the heart? When it's with artery. Away. So remember, A is away. Artery is away. The blood from the artery is pushing blood into the body away from the heart. And then when it's returning, it goes up through the vein and to the heart. So vein carries blood to the heart. Arteries carry blood away from the heart. Okay? Always remember that. How many layers of the vein and arteries is there? Y'all should know this. It's in the ebook. It's in the phlebotomy ebook or the Prep for NHA ebook. And it's also in our phlebotomy study guide. Not 4. Yeah, it's 3 layers, okay? It is 3 layers. We have 3 layers, which combines our artery and our veins. Now, whenever I say blood vessel, give me another term. See, look at that. Now you're not going to forget, though. Whenever you have... what's another word for blood vessel? What's another word I can say? Blood vessels. What's another word, y'all? What's another terminology I can say for blood vessels? Blood vessels are really small. Capillaries. I know that's right. Capillaries. Yes, it's in our capillaries. Okay, so our blood vessels, another term for that is capillaries. What in our POCT? When it comes to POCT, we know that we could do our HCG. I'm just kidding. Well, we know that we can do our PTINR, and we can also do what? What else can I do? Yes, and how do we collect a proper capillary? You got it. You will puncture. Ooh, I don't want this because it's mixed with a lot of tissue fluids, right? I don't want that. I'm going to wipe it off, and then I'm going to squeeze, collect that second drop, and I can get my glucose or my PTINR. I can do my H&H. What is H&H, you guys? Absolutely. It's hemoglobin and hematocrit. Describe to me, what can I find whenever I do collect my hemoglobin? What can I find? What am I really looking for? Hemoglobin contains what inside of it? Yes, oxygen in the what? And my red blood cells. And whenever I'm checking for my hematocrit, I can find my what levels in my hematocrit. What levels can I find in my hematocrit? If my hemoglobin will give me oxygen within my red blood cells levels, if I have my hematocrit can give me my level of, if I'm anemic, iron. Yeah, it's iron, okay? So we have our iron, which is our HCT, our hematocrit, and then we have our hemoglobin, volume of iron, right? And then we have our hemoglobin, that's oxygen within our red blood cells. Now, if my doctor were to order an H&H, which tube can I collect that in if I'm doing a venipuncture rather than a capillary? A dermal puncture, my lavender. So what additive is needed? So what does CBC stand for, you guys? Is a complete blood count, and my complete blood count will be sent to which department? Hematology. Hematology stands for what, you guys? The study of our red blood cells, or of our blood, yeah. The study of our blood. Now, whenever I were to collect this beautiful tube here, and it also contains EDTA, of course, which department and what is this tube used for? What is this? What is it used for? What is? Blood banks, yes, it's for blood bank, and it's just that, blood bank. Okay, we are sending it off for us to see what type of Daddy, I can't stand you, man. Who you, baby? That is not a paternity test. I love it. I can't stand you. But yes, it is blood typing. I need to know if I'm A positive, B positive, O neg. So if I say O neg, if I say O neg, you are considered to be a what? If you have Yeah, it's a universal donor. Beautiful. Remember, we always associate the 16 to 18 gauge with a blood bank, and that also that pink tube goes along with the blood banking. Now, hemoconcentration. I love that H word. Let's go through these terms super quick so we can get up out of this routine blood collection questions. Hemoconcentration is what, you guys? Hemoconcentration. What does that mean to me? What does that mean to my fam? Hemoconcentration is what? Oh. And we already said this before, but we're going to say it again. So abnormal ratio of plasma and red blood cells. And how can I prevent hemoconcentration? How can I prevent hemoconcentration? So prevent hemoconcentration. Concentration. Okay. Not leaving on past 1 minute. What else can cause hemoconcentration? I mean, how can I prevent hemoconcentration? Avoid what? Your patient should avoid. Got it. Avoid pumping the fist. Avoid fist pumping like this, the vigorous fist pumping. And what else can we do? What's the last thing that we can remember to do or prevent? We're not going to leave the tourniquet on too long. We're not going to avoid. Say something. I did. What can hemoconcentrated blood do? What can hemoconcentration blood do to your values? And which one? Yes, it's elevated. Let me see, elevated. Potassium level. Man, this is really upsetting me. Okay, elevated potassium levels. These are the ways that we can avoid hemoconcentration, all right? What about petechia real quick? Petechia is what? Red spots, yep. Petechia. Yes, thank you. Petechia is red spots, but it's rupturing of capillaries. So bursting, let's go bursting capillaries. Bursting caps. And how can we prevent that? Nope, that's hemoconcentration. Yes, you got it. Avoid placing the tourniquet too tight. That is petechia. Okay, so our next term will be, so we went over hematoma, we went over hemolysis, we know about hemoconcentration, and now let's talk about homeostasis. Homeostasis. Yes. 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 Yeah. Oh, you're trying to visualize it? Okay, so first, remember, you will not see hemo concentration is not something that you will see. You can't even see it in your specimen. You will have to send your specimen out for it to be calculated. Okay? You will have to send that specimen out to the lab for them to calculate different values. You know, whenever you're doing your CBC, right? You have your MCV, you have your white blood cell count, you have your MCT. These are different type of values in the CBC. Just like whenever you're collecting anything with plasma, let's say that our blood is hemolyzed. This is just an example, right? Let's say our blood is hemolyzed, and now it's giving us different levels of my plasma. It's supposed to be at 50%. This is just an example. It should be at 50%, and my red blood cells should be 20%. But because I left my tourniquet on too long, or they're doing this, or now my values of potassium and calcium has been elevated, it's going to play a little bit with my plasma versus my red blood cells. But this is not something that you can see. You would have to send it to the lab for them to calculate the values. Ooh. Okay. 55. That is such a good question. I've never thought of it on a cellular level. I have never thought of it on a cellular level. That is a great question that I do not have the answer to. But that is a wonderful question, though. I'm going to look into that. Let me write that down. Hemo concentration. Hemo concentration. Cellular level. Mm-hmm. 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 So maybe the red blood cells would be a little elevated rather than the plasma being elevated. Okay? But I want to look that up. That's a great question. I never thought about it on a cellular level. I love that question. Let's see. So we talked about routine collections. Homeostasis. Homeostasis is what, you guys? What is homeostasis? It's the balance. Yes, it's the balance of the body. That is what homeostasis is. Remember, it's when the body is at ease instead of a disease, right? It's in a healthy state. This is homeostasis. Now, how can I promote hemostasis? Hemostasis. We have homeostasis and hemostasis. How can I promote hemostasis? Applying pressure. Now, when we're applying pressure, remember, if our patient is not on an anticoagulant or a blood thinner, we should not be there more than how many minutes? 5 minutes, right? We should not be there past 5 minutes. Absolutely. So those are the H terms that I really want you guys to know when it comes to routine blood collection. So remember your main veins. This is a sum up. Remember your main veins. Remember the order that they come in. Remember what they are used for. Know what veins is for, and know what artery is for, or why we would puncture an artery and what would happen if we puncture an artery. If your patient is on a blood thinner, remember what to do is apply pressure. If you are bending an arm, let's say they just got done with a venipuncture, and they're going like this. What can that cause? We just got done doing a venipuncture, and they're just like this. What can that cause? Yes, it can cause a hematoma. So whenever you're done with your patient and you say, hey, can you apply pressure for me? And you see them wanting to bend the arm, say, no, 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 no. It's either you can raise it up, hold it, and apply pressure, or just simply apply pressure. Now, when your patient is taking any type of Coumadin, warfarin, or 81 milligram, 81, yes. You on point. I love it. So anytime they're taking an anticoagulant, or they any type of anticoagulant, remember you're always going to apply more pressure due to bleeding time. They come into you. What if a patient comes to you and says, hey, I have a history of syncope. What do you do? What do you do? Right. You offer them a reclining chair, or you take them into a room if that's available for you to have them lie down. What is syncope? Fainting. What are the signs of syncope? How do I know that my patient is kind of looking like, ooh, you good? What's wrong with you? And then they start to sweating. Yeah, they're starting to sweat. Their color starts to change. Their eyes is going like this, and then they're gone. When your patient is in this mode, they're about to pass out in syncope or maybe a seizure. What is your main concern as a phlebotomist? Exactly. Our main concern is removing that needle. So we're going to pop off that tourniquet, remove it. It is done. We're going to remove that needle. We're finished. No more. Even if my lavender is the tiny thing and I'm like, dang, man, I see you not good, but I'm going to collect this little lavender right quick. No. Okay. We just stop. Just stop. We're finished with you. Okay. With the glycemia, if you see your patient tells you that, hey, I had something to eat, remember, we're going to call the doctor. I hate it here. I hate it. I hate it. I'm back in for anybody that's on the live. I'm back in. Y'all back in? We back in? We're good? Okay, we're cool. Oh no. I hope she sees it. Let me see. My chat. Where's my chat? Okay. Yes. Yeah. Yeah. Oh yeah, we still stopping it. Not even if they laying down, we still gonna stop it. We're gonna be like, hey man, that's it. You gone. No, but you really do stop it. We stop it. No matter what, if my patient is like this, we stop it. We're not even going to try to collect that little light blue and be like, you know what? Anybody that's trying to record, I just let you record. So go ahead and record that. Yeah, we stop it. We're not even going to, I'm not even going to mess with you. We stop. We might be like, you know what? This little blue right quick. I don't want to cue in this. Just lay right there. You ain't going nowhere. Again. I would not. You give them another day. you give them another day. Tell them, hey, if it's okay with you, I still need to collect some more vials. Let's reschedule for another day. Please make sure you hydrate and then be prepared. And we're gonna go through the same thing again. I would always use blood draw. You document. Remember, you document everything. So if they said, oh my gosh, okay, so you didn't get enough? No, unfortunately, I did not. And they're like, oh, but dang, can you just continue? I know this is going to happen. This is a constant thing for me. You document. You document. Don't just go ahead and redraw. You document. Usually I won't even redraw the same day. I'll tell the patient to come back another day. But if they're insisting, you will always document. Always document. We work faster the next time because you start to get to know your patients. I'm gonna get my big tubes out the way before that patient go out on me. But no, seriously. And then sometimes you don't have to spend some of the specimens. You don't have to send it out right away. Some of them, like your SST tube. Let's say I collected it today, right? I'm going to spin it down. And if you tell me that you're coming in tomorrow, you're not supposed to. But if you tell me that you're coming in tomorrow, I can save that specimen. Or I can just send what I have and then I'll collect tomorrow the rest of the remaining. That's what you can do. But absolutely. Let's say that I collected I collected big vials today. I collected my tumor, my cancer marker. That's a CA 125, right? I collected that, and that's a big SST2. I have another one that is my TSH, my lipid, and wait, somebody said something, I didn't hear you. Or maybe that was just me talking. Wait, I couldn't hear you. Oh, okay. Okay, so I have my TSH, my lipid, and my CMP. That considers to be a big vial, right? So I did my 2 SSTs, and then let's say he ordered a CBC and an ESR. Sometimes the ESR can be combined together, or sometimes they want you to do 2 different vials depending on where you work. Sometimes they'll make ESR its own and CBC and A1C together, right? So that's 2 lavenders. So 1, 2, that's 4. So I'll collect my cancer marker. I'll collect the TSH, lipid, CMP. That's my 2 SSTs. I collected two SSTs, and you passed out on me. Okay, I'm done. But on my labels, remember, I said I'm going to collect my cancer marker, my TSH, my lipid, my CMP, my CBC, and my ESR. So on my requisition form, it's going to say I have all these vials. In order for me not to get like a TNP test not performed because I never sent those vials, and it also is still on my labeling, I need to go back into the system, cancel or put in my CBC and my ESR. I'm going to unactivate them, okay, in the system, because before, when I did it, I clicked on everything. Okay, I'm collecting for my cancer marker, I'm collecting for a TSH, lipid, my CMP, my CBC, and my ESR. But really, I only collected my CA, which is my cancer marker, and my TSH, my 2 SSTs. I need to remove that I collected my CBC and my ESR. Remember, you document everything. And it won't even let you progress or move forward without you putting a reason as to why you're not collecting a CBC or you're canceling a CBC and an ESR. So you'll put in the system, patient had syncope and will return for to collect for a CBC and an ESR. This not only covers you, because remember, everything is timestamped. So this covers you, and this lets the nurse or the doctor know, okay, I'm not going to have my results for my CBC, nor am I going to have my results for my ESR, but I do have my cancer marker and my TSH, blah, blah, blah. So now you reprint your labeling. You reprint your requisition form. The number one way for them to send you a TNP is if we said that we collected all of this stuff, but they only received 2 samples. So now they're like, okay, so where's the rest of the samples? So they're going to call you and say, hey, where's your CBC? Where's your ESR? They're going to be looking through it for the accession number. So not only are you canceling the CBC and the ESR, you have to make sure that accession number is not there anymore in the system. Remember, the accession number is the same number that is tracking the patient's samples. All right, so we have to uncollect everything. Note that we uncollected our CBC and our ESR, and then proceed. But our requisition form, whatever we collected from our patient, has to match our requisition form, and it has to match our labeling as well, or you will get a TNP test not performed. So you document everything. Always remember, if there's not enough sample for your CBC, you only got a little bit. And even with a CBC, you don't need that much blood anyways. They can run it. They can run it with a little bit of sample of blood if you only have a CBC. But let's say that you didn't get enough blood in your lavender. Oh, okay, so I'm gonna go back into my system and say, unable to collect CBC, vein, blue, patient will return. That's it. Always document what you're doing, and do not forget to uncollect what you've previously collected. That's why they always tell you, if you're working in outpatient, the hospital is a little different. When you're working in outpatient labs, and they always tell you, don't pull all your labels yet until you bring back your patient, and so your patient can verify and you do all of this. And that's when your patient's in front of you, you print out your labeling. Sometimes you pre-print and then you go call your patient, and now you got to cancel some stuff because you don't have enough blood samples. So always remember, if you don't have enough, uncollect in the system, reprint a requisition form, and make sure that the label and your requisition form match what you are sending to the lab. Period. Okay? Do you understand what I mean? Okay. And always remember to, your accession number 2, make sure it's not in the system, because they will try to look up the accession number and say, I see that you have a CBC, where is that? In actuality, you didn't even collect it for real. You just forgot to uncollect. Another thing is free drawing. I love to free draw. I'm the queen of free drawing. But that's not always the right thing to do, because sometimes you collect more samples than you really need, or sometimes you don't collect the right tube. Sometimes it's asking for a sodium heparin and you collected an SST. Okay, and you can't allocate that. You can't just say, I'm gonna take the serum from here and place it into here and send it off. No, because they said they needed plasma. So free drawing is whenever you just kind of look at your orders on the computer, and you're like, okay, you need a CBC, you need an A1C, all right, bet. Or you need a gray top, bet. And you're such a good phlebotomist, you already know what they need. So you're just picking out tubes. You don't even have your labels for real. The doctor didn't really put in the orders. You just kind of looking at their history and you see what they need. Because this is a routine. So you know what a routine is. A1C, CBC, CMP, TSH, lipid, urine. These are routines. So you already know, I'm going to need 2 lavenders, 2 SSTs, give them a urine cup, go. And you're writing in this information on just a label. That's not always the way to go, because remember, what if the doctor add more things and they needed testosterone on your patient? Or the doctor needed a PSA, right? And you didn't collect a red top. If it's a PSA total, sometimes whenever it's a PSA total, you need a red top. Sometimes whenever it's a testosterone total MS, you need a red top instead of your SST. So It just depends. So free drawing, I love free drawing, but then again, there's pros and cons to free drawing. All right. So be careful with free drawing. Labeling, of course, make sure it has all the information on there: the time collected, the date, the first and last name, the doctor's information on it. How do we verify our patients? Actually, how do we verify our patients? Absolutely, it's our first and last name, date of birth, and then if you're in the hospital, remember your patient always needs their wristband. You cannot proceed if their patient does not have a wristband. You need to let the nurse know, hey, can you please place the wristband on? So remember, if your patient is unconscious, the only person that can verify your patient would be that wristband, and you need to call in the nurse and say, hey, is this so-and-so? Yes, that's so-and-so. I don't care if your mama, your daddy, your wife, your sister, your little blood, your dog, your cat, your raccoon. I don't care who's there. I need that nurse to come in and tell me, oh, yep, this is Milka, 11/11/23. Okay? All right? We will always, your fish. I don't care who it is. We always got to ask the nurse to verify. Remember, if you have a stat is collected within 10 minutes, and if the patient is not in their room, you need to locate the patient in order to collect that specimen always. Let's say you have an IV. Remember, IV and mastectomy and fistulas. These are the three important ones. IV, if I can go to the other arm, I will. But if I can't, remember there's a protocol for that. Who remembers the steps for IV? Who remembers the proper steps for IV? For how long? And you will wait for? And then? And then what do I do? Okay, you draw. Okay. What else? What do I do with that sample? Not 10 minutes. We're going to at least wait 2 to 5 minutes, or 2 minutes. 2 minutes. 5 minutes is the max, but you will wait at least 2 minutes for the nurse, well, for everything to stop, right? You'll wait. You'll wait, and then you will remove 5 milliliters of blood, and after that, and then you will continue to draw, and then go ahead. What are we documenting? You know, we document everything. What are we documenting? What are we placing on that document? The time, yes, of course. What are we documenting? How did we collect this? Who's the patient? What's wrong with this patient? What can interfere with this specimen? Due to what? Yes. So now you need to document and say this specimen was collected from an IV therapy patient. All right. Now, that was for IV therapy. What about a mastectomy? A mastectomy, if this side is the side that has been operated, we will usually go on the opposite side. Now, let's say we have a double mastectomy. What are we doing? So if my right arm is if my right arm is 3 years and then my left arm was 17 years, I'm going to draw on the arm that has been 17 years. Or I will also ask my doctor, hey, the patient has a double mastectomy, which arm would you prefer? Now, whenever there's a specific venipuncture that we need a doctor's order, which vein or which location would you say that we need a doctor's order? Yes, the foot vein. We will not just go to that vein and say, "Hey, I can't get in your arm." Oh well, I'm gonna go to your feet. You need a doctor's order for that. So, with a fistula, do we draw from the same arm that the patient has their dialysis fistula, or what do we do? What's the protocol for that? Opposite arm, always. It will always be the opposite arm. So those are the three main things that I want you guys to remember. A fistula, which is the dialysis port, your mastectomy, and an IV patient. Okay. Do we have any questions on tourniquets, the site, the main veins, the arteries? Aorta is the biggest what? Wow. Artery. And we have vena cava is our biggest what? Is our biggest vein. And remember that the veins carry deoxygenated blood and our arteries carry oxygenated blood. Winged infusion set is a what? Winged infusion set is a what? It is a butterfly needle. You see how they try to trick us with these vocabularies? Not me. Not me. Trying to put these vocabulary words. You might get out my face. I know what that means. Okay. Let me see. Concentration. The cleansing site. Remember that different tests require different type of cleansing. So if we are doing a blood culture, remember you will use a what? What type of antiseptic? Is our coral prep. Whenever we have just a routine, I'm just getting a CBC, we're going to use a our alcohol pad or alcohol wipe. And then if I have my alcohol level test, I'm using if a patient is allergic to shellfish, you're avoiding. Alrighty, we got that. Now let's go into some OSHA questions. We understand everything about routine blood collection, right? I know, y'all. It's a lot. I told y'all it's a lot. It's a lot. Okay. I'm telling you, man, it is. I'm sorry, y'all. Okay. So here we go. So we went over routine blood collection. We did our order of draw. Real quick, I'll go through the order of draw. Remember, we have our blood cultures. Blood cultures are collected in their little order. And what is it? Absolutely. And what does that mean? Okay, so one has oxygen and one is no oxygen. What little tube goes right along with our sterile blood culture? Yeah, it's our yellow tube. And what is the additive inside of our sterile blood culture? Yep, the additive that's inside of our sterile blood culture. Nope, in the yellow container. What is the additive? Oh, she said it is SPS. It's our SPS, which is the same thing as, remember, is our little blood culture. Let's say we don't have our little blood cultures, and we can only associate our yellow top. That's going to be that, our SPS, ECD. Wonderful. And then we go to our next one. Remember, that's coagulation study. Which tube is that? Are you still trying to figure out how to record it? Okay. We have our light blue tube. That is a sodium citrate. We know that falls under coagulation study. And then we have our red top. What's important about the red top? What is it considered to be for? What is our red top? It's a non-additive, and it's also considered to be a clotting activator. What makes it different from a serum separating tube? Yeah, no gel. But the question was, what is the difference between a red top clotting activator from a serum separating tube that also contains a clotting activator and it doesn't have no gel? So that means if we were to spin it down, it gives us our serum, but there's nothing to separate the serum from the red blood cells. So make sure whenever you're pipetting, be careful because you can mix the red blood cells again with the serum. Now we're going to go into our next clotting activator, which is our serum separating tube. What do I need to know, y'all? When using this tube here, what do I need to know? What's my SSTs? Yep. What else? Wait. Right, polymer gel, and I need to wait at least 15 to 30 minutes. And this tube goes to which department? Chemistry. Oh, somebody wanted to, here you go. I'll accept you. Come on in. Come on in. If you wanted to join the live, now you can be on the live. Yep, you will send it to chemistry. What does CMP stand for, guys? A CMP. What does CMP stand for? Yep, it's a complete metabolic panel. And then the BMP stands for? Yep, basic metabolic panel. Remember that when you're checking for a CMP, that's okay. Whenever you're collecting for a CMP is more. It tests for at least 18 things out of the BMP that only tests for 8 different things. What does our lipid panel test for? It is our cholesterol levels. And what does cholesterol consist of? What's inside of our cholesterol? What are we looking for? Triglyceride, yes. One more, 2 more. Triglyceride, what else? What else? What does our lipid or cholesterol else have? We have our triglycerides. Come on, we know this because when we go to the doctors, we be like, oh, sure. What does it stand for? What? Give me the acronym for it. Low density. Okay, my LDL and my HDL. So we have our triglyceride, our HDL, and our LDL. Okay. Now, if we're not checking for a lipid panel, because remember the lipid panel is the cholesterol, that's everything in total. Now, if I'm only checking for my LDL, HDL, and triglyceride, what is that considered to be? It's a C word. It's a C test, and it's not CMP. I want to see who got this. I want to see who. Somebody said it. Stop! How you knew that? Yo, smart self. You made me. How you knew that? I'm so smart, man. You're so smart. Yes, it is called your coronary executive panel. I love that for you, girl. Okay, so They're only testing for your triglyceride, your LDL, and your HDL. It is your coronary executive panel, okay? And remember that lipid is considered to be a fasting test. And in real life, in the field, I have never asked, are you fasting for a lipid? That's just me. Now we know we asked for that. But on the exam, lipid is considered to be a fasting test along with your glucose. A1C. When we talk about A1C, we know that A1C is collected in a lavender top, but what is it really checking for? Explain to me what an A1C is really checking for. Absolutely. It's for a 3-month period of time. So I always like to, okay, yeah, I'm going to post, I'm still recording. Recording, so I will post this on YouTube for anybody that missed it, okay? So it does record over a 3-month period time span. If you, in January, you tested for it, you can't test for it in January, March, April, to like March or April. Insurance won't even let you do it. That's coming out of pocket, if anything. Okay, let's go to OSHA. OSHA should be our last big topic. My gosh. OSHA. What does OSHA stand for, y'all? What does OSHA stand for? Say it again. Say it again. OSHA stands for all right. Occupational Safety Health Administration. Absolutely. Now, when we talk about OSHA, remember the main things that they need you to know when it comes to OSHA. You have to know safety and compliance. Okay? That's where our PPEs come in. That's for the safety of the employee and then the health of the employee. All right. So PPE stand for, what is the main PPE that a phlebotomist will always use? It's our gloves. Oh, wonderful. So if with that being said, if our personal protective equipment is PPE and we're supposed to look at all of our patients or everybody with, like, you're infected, what type of precaution is that called? Standard precaution. Remember, our universal precaution is the PPE. That's what's protecting us. Now, there's different type of precautions. We have our universal, our standard, our airborne, our droplet, and our contact precaution. When I talk about contact precaution, what type of PPE is required for contact precaution? Yep, my gowns, my glove, what else? My mask. So it's my full PPE for contact precaution. I want you guys to remember that's for MRSA or C. diff. Remember them. Let me put that in the chat. I want y'all to remember that. Okay, so C. diff. Actually, I don't even think I need to put it in the chat because I'm going to post this anyways, but we don't. C. diff and MRSA. MRSA is contact precaution. Okay, when I say airborne precaution, what type of PPE is required? What kind of mask? My N95 mask is airborne precaution, and that also falls for ATB. Now, when I tell you that this is a droplet precaution, what am I referring to? Just a regular mask. I'm gonna smell your breath. Remember, we love to smell these people breath in the morning. We just gonna have a regular mask for a droplet precaution. If they have the flu, I can't believe they tried us with COVID. I don't even want to put that in the chat. But flu, we're gonna stick with flu, okay? Influenza. Let me put influenza. Influenza, which is also our flu. And then the last one that we have, we did airborne precaution, droplet precaution, contact precaution. Pneumonia or bronchitis would be an airborne precaution. Airborne precaution. Pneumonia or bronchitis will be a airborne precaution. Yeah, surgical mask. Yep. Which is our N95 mask. Okay, so we went over all of the expected precautions. All right, let's talk about accidental needle sticks or blood. Let's talk about BBPs. What are my BBPs, you guys? We have which one? Well, I see HIV. We have and Hep C. Wonderful. Hep B. Here we go. Hep B. Oh, why did I write that? Hep C. Here we go. The main one that your employer will try to push onto you and be like, hey, you need to get this is which one? Here's my Hep B. That's a vaccination. That's the one that they're really going to focus on the exam, okay? They're really going to focus on that one. They're not so much going to talk to you about HIV for real. But if they do, remember what type of PPE is required for an HIV patient? Just your regular gloves. Yep, just your regular gloves. What is the number one way to prevent the spread of infection? Prevent spread of infection is what, y'all? Hand hygiene. Hygiene. It's hand hygiene. And for how long, y'all? Yep, it is 20 seconds for hand hygiene. Accidental needle stick. How can I avoid that? Or how can I try to prevent an accidental needle stick? The number one thing is what? Do not recap. Now, let's say that there's ever a time that you would recap. How would you do it? If I ever needed to recap, what would I do? This is my needle. This is my cap. Am I just going to go like this? No. How would I recap my needle if by any chance I would ever press down on the cap? So like this. No. If we were ever to recap. Nope, you will place it on the surface. You place it on the surface like this. You take your cap. You take your needle and then you insert. Okay? That is the way for you to recap, the safe way to recap a needle. You will never, unless you're a nurse. Oh, hey, babe. My husband, y'all. If you ever needed to recap, but that's the only time a nurse would ever recap is if they pull the medicine from the syringe, right? So they're not walking around with the needle like this. They're gonna place it on the counter, and you just take it and go like that. I don't ever do it. I'm throwing that whole thing away. I'm throwing that whole thing away. Forget that. We're not doing that. We're always applying our safety. Okay. Let's talk about what goes into a biohazard bag and what goes into into our sharps container. What goes into our sharps container, guys? What about our blood smears? Is that plastic or glass? That is glass, and that definitely needs to go into our sharps container. Now, our biohazard bag, what goes into that? Mm-hmm. Yep, our soiled items. So if it's saturated in any, oh well, dang. Oh well, dang.